Hi, what the HealthTech listeners. I'm your host this week, Mark Fewster, Chief Product Officer at Radar Healthcare. This is the podcast where we tackle some of the trending topics, ideas, and best practice in health and social care. Welcome to this special episode of What the HealthTech, where we celebrate Radar Healthcare's recent accreditation to LFPSE V6. Today, we're joined by Jack Forshaw, Project Manager Lead, LFPSE Champion at Radar Healthcare, and Marcus Manhaes, Head of Learning from Patient Safety Events and Machine Learning at NHS England. Together, we'll explore the intricacies of the LFPSE framework, discuss Radar Healthcare's journey to achieve LFPSE V6 accreditation, and also share invaluable insights on improving patient safety across healthcare organisations. So thanks for joining us this week, Marcus and Jack. And I guess, Marcus, if we can start with you, please, and just going through what you think the key differences are in advancement in version 6 LFPSE versus version 5.
Yeah, so before getting into the actual details, I think it's important to mention why we have this progression, and it's something that is going to happen over and over again, because what prompts a new version for us is, one, we have a huge backlog that we are prioritizing things. So say, for example, for V6, there is a number of things that are being prioritized to be included in this version, because now is the time to put them into production. But also, a lot of things are based or as a result of user feedback. As people have been using, they're contacting us and say, this question doesn't feel right, and those kind of things. And then we take the opportunity to revisit the feedback that we're receiving from the users. And the other thing is, when we analyze the data that we received, and then we start finding problems and things that we need to improve as well. So those three factors kind of come together when we're planning the release of a new version. So for V6 specifically, we have the DM&D. So we're bringing together the kind of the coding of medicines. So it's supposed to be medicines and device, but we are relying, or is more reliable, the information we get on medicines, and that's what we are rolling out at the moment. So this is one new thing that's being introduced in this version. The other thing is that is part of this release, but can be done with V6. There is a deletion of records.
Yeah.
So there's another functionality that is that has been rolled out within the V6. So users will be able to delete incidents that they believe do not meet the LFPSE requirements and have been submitted as an error. We received, when we looking at the data that we received a lot of test records, and we're making this available so the user can go and clear those incidents from their kind of that data.
Yeah.
And a main key thing is the supporting questions for PSERF. So we've been rolling out the PSERF. So we need to also put the LFPSE into context, that it's not just the tool, but this is part of the patient safety strategy. And there are other parts of that strategy, and we all kind of supporting all those moving pieces. And one big part of the strategy is the PSERF, is the new serious incident response framework. And V6 has the questions and the workflows to support trusts to then make better use of that and start doing the transition into PSERF, and that will enable the retirement of STIs system, because one of the goals that from the beginning was to unify those systems and have a single port of data collection. And to do that, we need to have the questions embedded in the LFPSE taxonomy that will enable the replacement of or the decommissioning of styles. So those are the kind of key points there. And in terms of the feedback that we received, things like specialty, service type updates, incident location lists, those all have been reviewed. People's actions, wording on questions and help. So all of this has been adjusted and has been rolled out as part of V6.
I've got a question. I'm already going to go off a little bit off topic. Apologies. So you mentioned the version in there, and we've gone from version 5 to version 6. This might not be a question you can give kind of a definitive answer to, but you're saying it's a moving thing. It's going to be version 6, version 7, version 8. For people out there who are on versions at the moment, do these versions have a shelf life? Is there kind of an expected, we will support version 6 for, however long that time period is? What might that be?
Yeah, so from the beginning, we made a commitment that we would support each version for a minimum of 2 years.
Okay.
And as now V6 is out there, but we're still supporting V5, so we're not setting any deadlines for people to transition. Obviously, we're leaving that to the providers to look at the benefits for them in that version and start talking to their vendors in terms of when they can get the new version. But it's down to the providers to realize, what the benefits are there for them and how quick they want that to be updated. In terms of V7, so we already have a backlog, so things that we couldn't push at this point that we are working on, and it's going to come on V7. We don't have a date for that yet. We haven't started development, but the way that we are working is to have this very close communication with the vendors. So we always tell them what's coming in advance. And as soon as we are ready to start our development, so we make sure that the vendors are aware of what's coming and they can kind of prepare their development as well. So try to synchronize that, because as vendors, you have to assign that work within your product life cycle and all of that. We also have to do the same in our product, because we do have the portal that needs to be updated, and all the checks and validations and the database that needs to be updated on our side. We just make sure that we both work during the same period to get there at the same time.
Great. Is there anything you can share from V7? Any kind of highlights? Anything kind of major that might be coming as part of that planned update?
So there are things that we are exploring to prioritize. I can't say that it's going to be for V7 or V8, but we want to touch on the patient involvement. We want to revisit the situation with risks and outcomes. So that you have good care, risk outcomes, and incidents. So we want to revisit that as well, and continue receiving feedback from the users. And we will be making adjustments as we go along. But this is all going to be consulted with stakeholders, so providers will know what we're planning to do, have the opportunity to comment on those plans. And so at the moment, we still have a backlog of things that we didn't push into V6. They're sitting there for V7, and there are things that we're looking at developing in the future that for sure is going to be included. I don't know if it's going to be V7.
That's fine.
Yes.
I was just fishing. It's fine. So kind of, I guess the big question is, irrespective of versioning. So I know we spoke about this on a podcast 3 years ago, something like that. So LFPSE, how how is it going to deliver tangible benefits, I guess, at a national level, but then I guess also for each healthcare organisation? And what can they expect almost to get back now that they, in most cases, I'm assuming, would implement and have implemented at least version 5?
Yes, I think that again is looking at this not just in just the tool in isolation, but as the benefits from the patient safety strategy as a whole with PSERF and all of this. So one is what we're proposing is a big change in terms of bringing more flexibility in a way that incidents are reviewed, and at the same time promoting this sharing of information and more transparency across the system between organizations. So that's why it was important to bring to a single common language. That was a single taxonomy, a national
Yeah.
taxonomy, to enable this data sharing across organizations. And I hope there will be a lot of benefits from that. But also is looking at the flexibility that this is bringing, because before there was a very strict way of looking and investigating incidents. And now we're saying, no, you don't have to do this for every single incident. And we're giving this local autonomy for people to apply and focus work into areas in which the most impact may be achieved.
Yeah.
So is giving that local autonomy and this flexibility that people need to then decide, okay, those types of incidents, I will adopt this type of response. And for this other type of incidents, there will be a different approach and a different response. And so those are the things that we believe that this is going to help and bring tangible benefits to organizations. But a key thing is also to develop a proactive strategy for learning. So instead of just being, okay, I got an incident and then I investigate that. So it's very responsive. And let's be more proactive. Let's look at the data in different ways, not just, okay, this is the type of incident, it's classified in this way. No. Let's look at what happened, what things were involved in that incident, what kind of factors are contributing to the incident across a number of different types of incidents, and try to evaluate those contributing factors independent, as not as a reactive from an incident, but having a proactive strategy from learning and tackling those issues.
Yeah, that makes a lot of sense. And we do similar. I think we've spoken about the national taxonomy we're building out at the moment. And again, it's that concept of how do you get something where you can actually learn from it. Are you, or have you seen anything in the data that people have already been submitting? Is there anything that's kind of stood out from kind of people who are on version 5 on and have been submitting for say a year or so? Has the data told you anything yet?
We have limited resources on our side as well, and we've been focused on the transition and support organizations to transition, and only a month ago that we have our organizations transitioned. So we've been looking at the data, and we're finding at the moment we're trying to identify lots of data quality issues and trying to solve that, because that is also bringing some limitations in terms of what we can do with the data. So sometimes it's like, oh, those things are not completed because there is a problem in software. So organizations are not submitting their ODS code, so we don't know where the incident came from. So we're spending a lot of time trying to solve those data quality issues that are actually preventing us to progress with the kind of more generating insights from the data, because that might be wrong. Those insights might be wrong because those issues. For example, age of patient. There's a lot of issues with the age of patient. We have patients with like 300 years old. And so we want to try to do analysis. Our insights are not totally reliable at the moment. So we're trying to solve those issues. And yeah, so that's where we are at the moment, now that we got all the organizations on LFPSE, and we are working on data quality. We are about to release the data dashboard for organizations to be able to see their data and do some analysis themselves. But we're very careful in terms of the message about this, and be very clear about the limitations with the data that we have at the moment because of data quality issues. So we want to enable the access to data, but being very clear that first organizations should look at it to identify data quality issues with their own data, and any insights should be looked with a lot of care and caveats, and not taking as the truth, because that might be showing false insights due to limitations in the data.
Okay, great. Thank you. So moving on to yourself, Jack. Obviously, we're first to be accredited for version 6, which you were a big part of that. So can you just share some of the kind of challenges and milestones that we kind of faced, if you like, where we were working with the NHS England guys and internally, I guess, on us moving our system from V5 to V6?
Yeah, of course. I think we were quite lucky to start with, actually, that we had V5 as an established base of work. We've implemented several customers already and several partners to use V5 in various different modes and models. So we had a lot of almost evidence to use and lessons learned that we could bring forward into V6, which helped inform that build process. So really, milestones, getting it across the line was probably the biggest one. But I suppose that therein was the challenge, because the documentation which came across, it was quite granular, I think, and quite rightly, there's a very specific data set that NHSE are looking to capture, and it's important that we include that in the forms. So the first challenge, I think, was actually interrogating that information, transposing it into a format that we could understand, and then apply directly into our form in a way that was still user-friendly and manageable to an end user. So that was one of the bigger challenges, I'd imagine. And I think from a testing perspective as well, that was definitely my biggest thing, because I'd put in a question, we'd send it off to the API team to manage, and almost immediately I get feedback saying I've misplaced an apostrophe or put something in the wrong place and it didn't quite conform. So it would come back for me to fix again. And I think there's one instance where I think I went through 11 different versions of the same question set before I was able to get it quite right. So personally, for me, that was one of the big ones. The other challenges we had, so our V5 form, quite specifically, was a single LFPSE document, and it was driven by a single piece of logic in the back end of the system, which determined what LFPSE type it was. So incident, good care, risk, and outcome. And you had your governance questions in there as well. One of the key bits of feedback we'd received from V5 was, in terms of form design and build, it could be quite unwieldy to an end user if we're trying to add in local question sets and then maintain that. So we placed a great deal of effort into kind of separating these disparate event types into their own individual forms. So for the end user and a maintenance perspective, it's easier on an event by event level. But then, of course, you've got questions which appear in all different event types. So we had to almost quadruple the amount of work to get that initial data in. Saying that, though, I think the feedback we've had so far from the demos we've done has been really quite successful, and we've reframed the code now so that it is future-proofed to an extent. We can almost drag and drop local questions in and between forms.
Yeah, I think that's always the challenge, though, isn't it? Because obviously from Marcus's side, it's just, well, not just, but it's a taxonomy. And then not just us as a vendor, but I'm assuming this will be the case for the other vendors. Obviously, all of our products work in completely different ways. For us, specifically workflows as a true workflow rather than just a big form, that brings its own challenges in terms of not just us implementing it, but Marcus and the team actually understanding how our product works, which I think again has been quite a big part of this. Is a lot of the calls we've had with the NHS England team are, this is how our product works, this is how we're going to do the implementation of V6, just so that they get the nuance of what we do, because like I said, we're not the same as others out there. I mean, I'd go along with that in terms of some of the challenges. I think one for Marcus on version 7 or version 8, if we can have a better way of kind of consuming the taxonomy, that would be good. If we could do that by an API that itself, that'd be amazing. But I'm guessing that one's probably a way off. But
No,
I think
actually,
you're right.
this is something.
You can give me some good news.
No, this is something that we want to prioritize for V7.
Great.
This is one of the things that we want to tackle. We understand that this is a problem for you, and is a lot of it requires a lot of work from your side, not just you, all vendors, and we want to make that easier. So this is something that we want to change in V7. So then V8 will be much easier, it's smoother than it has been so far. So we understand, we hear what we're saying, and this is we heard similar things across all vendors, and yeah, we want to find a resolution for that.
Great. So just back to yourself then, Jack. For customers who are either coming onto V6 from nothing, or they're moving over from version 5 to version 6, how do we go about that? How do we do the implementation process with them? What does that look like?
So we've got two different methods for this. So obviously there's a different challenge from moving V5 to V6, just because the customers have got an established process in already. And fundamentally the form hasn't changed too much, but there's some new scenarios which we need to be cognizant of and capture, specifically, zero patient harm incidents. A lot of previous incident types have been built not necessarily with that in mind. So there's a bigger scoping exercise we have to go through to ensure continuity and that people still have buy-in for them. From 0 to V6, I think that's possibly easier, if I'm honest, because obviously they're going from nothing to something, and there's a more instantaneous buy-in. We're running a pilot at the moment for V6, which we're hoping to go live with on September the 2nd, where we've designed the form out with a partner. We've submitted everything for testing. That's going through now. But they've shared the form and the design with their board, their CEO, and it's come out, unilaterally really, really happy, and everyone's really pleased with what it looks like and how it performs in the staging environment. And they're really, really keen to get it up and running. So I think the buy-in for it is, there's a huge appetite for it. From an implementation standpoint, we'll work with customers. We don't want to necessarily run before we can walk with it. So we're taking it quite, sensibly and, assessing each implementation as we go, taking lessons learned and applying that to the next one. But generally, we take a look at how they want to implement first and foremost. Do they want to use the LFPSE form in isolation as it is, as currently designed, or do they want to integrate their local questions into it? If it's the latter, then we have a wider conversation about how they do that effectively to ensure end user buy-in, to ensure that customers, they're not overloading them with information that they need to capture and therefore see reporting rates drop, and just making the process as easy for them as possible.
Yeah, that makes sense. Part of the question I asked about the transition times and how long we might have for version 6 and version 7 is, I think that change from one version to another, even if it isn't a huge amount of difference in terms of questions, can mean it's quite a difference in a workload for the organisation, not necessarily from a vendor point of view, more so from a training point of view and for people, their end users, understanding what the question and responses mean.
I think there might be a hesitancy as well. No one necessarily wants to be the first one in. They want to almost hang back and see someone else do it and see what worked for them and what went wrong and then apply the benefits from that. So, it's you've got to be quite really positive with it, I think, just, excel the virtues and get everyone going with it.
Yeah, makes sense. Excuse me, just back to yourself then, Marcus, and back to the data then, I guess. So I know we've talked about this between us on kind of separate calls and things, and kind of ties in with some of the bits and pieces that Radar are doing. How are you looking to leverage kind of machine learning and I mean, ultimately, the big data you're going to be consuming from all of these different providers. How are you going to look at kind of leveraging the latest technology to kind of uncover insights from the information you've got?
Yes, so this is as you mentioned, we've been we talked about this before, and people might have heard me talking about this from other previous webinars and things that we did at NHS England. And yes, from the beginning, we've been trying to make the most of new technologies and explore what's out there, what's possible. But at the same time, we're trying to not to get into the using machine learning and AI as just as a buzzword and just say, oh, we're doing this. No, we need to, because there's a lot of pressure and say that you're doing something, that you're innovating, but actually it's looking at what problems you actually have and you're trying to solve. So in terms of patient safety, is about how can we provide actionable insights. So how to derive that from the data that is available to us and to enable proactive interventions. So that's the kind of the key point there that we're trying to solve. So there are so there are two sides of it. That is the tackling the problem in terms of NHS England has all this data to analyze and take and make the most of it, and very limited resources in terms of the people that can actually read the incidents. So this is a big issue. And so looking at from that perspective, what internal issues we have and challenges that we face that we need to be tackling. And so we've been developing machine learning models to identify anomalies within the data. So identify unusual types of incidents, unusual patterns within the data, and then select them. So prioritize those kind of incidents to be then analyzed by a subject matter expert that will be able to make sense of that and say, actually, this is not the machine hallucinating. Actually, there's something interesting here. Yeah, this is a rare thing, but is a known issue. It's rare because, for example, is a radiotherapy issue in terms of not every single patient is going through a radiotherapy treatment. So it's rare because it's actually rare, but it's not a novel risk. It's something that already know and things. So that we still need the human knowledge and review in there. So this is about the anomaly detection. That's just kind of the name and things that in machine learning that's very the people are exploring to use. And then there is something about predictive analysis for risk identification. So how can we is to establish early warning systems and that kind of thing. So though we are doing the work on our side to develop those models, I must say that it has been slower than we would like it to be, because of access to clinicians. Because if you're developing anything in machine learning, you need to validate the results, what the machine is telling you. It's all about validating and understanding that they are doing those things because, one, data quality issues is a big key point there, that it might impact on the results that you're getting. And second, you need to get that feedback to the machine in terms of, yeah, this is not interesting, or this is not relevant, and start to get to the actual interesting point. You need that guidance and validation, because you need to establish a certain degree of confidence on the model, how reliable the model is, and all of this. You get to that point with feedback, and that feedback has to come from someone that understands and can look at the outputs. So we've been very limited in terms of the expert resources that we can access at the moment and help us on that process. So that's why it has been quite slow. And we've made some attempts to call for volunteers from providers, and we're still doing this. So people that are listening to it, and you are an expert in reviewing patient safety incidents within your organization or from a number of organizations, please get in touch, because we need people to work with us in the evaluation of those methods. But then when it gets to the provider as well, so we're making sure that we send in that whatever insights we got, we can send them back to the users. And this is something that has been included in the taxonomy, that is the outputs from the machine learning. However, we are not switching this on at the moment because we haven't completed the evaluation stage. We can't really rely on the information that we're sending out. So there's a lot of potential. The aim is to be able to facilitate the generation of actionable insights and support or enable proactive interventions. There are models in the industry very well developed and tested in other industries that we are learning from those experiences and we are applying on our data, but it's the validation of our models is still something that is holding us back and is delaying the full implementation of this. But also, there are some considerations that we always have to talk about when mentioning machine learning, is the data quality, and also ethical considerations as well. Is about protecting patient privacy, make sure that the algorithms are not biased in any way. So it's all of those issues that we also trying to address before we can present something that is reliable and ready to be consumed to you all. But in addition to that, there is a lot of organizations trying to do similar things in silos, and we are open to work with them and see how we can help each other in terms of developing those patient safety related machine learning methods. And so anyone out there that is doing that work, please get in touch, because I think it's very important to avoid duplication in the system across NHS organizations. So it's good to have to talk to others, avoid duplication. Let's put our resources together in terms of achieve something, instead of lots of silos trying to do the same thing and that kind of getting at the same stage with the same problems. So let's talk more, integrate more, and share experience, not just about what we learn from the incidents, but how we get the insights out of the data.
Yeah, that makes a lot of sense. And actually, if you picked up on the point that I was going to make, was actually involve us in that, because we're doing the exact same thing, because we have kind of LFPSE as the core form for some organisations, using that data set as well, but then using other data sets that we have from some of the private organisations who aren't necessarily supplying data to LFPSE. So we get the wider picture, for want of a better way of describing it, because we're working across lots of different healthcare systems. And we are all, in essence, trying to solve the same problem. So yeah, we would very much welcome working with you on that. Just moving on to the next question then. So we've kind of touched on it a little bit with Jack, but yourself again, Marcus. So I guess knowing what you know now, working with other vendors as well, to be fair, any kind of tips or best practices you've seen for anyone kind of moving? I guess obviously we're talking V5 to V6 now, but just anything that you think people will need to be aware of, any kind of changes that they kind of need to focus on? You mentioned PSERF obviously being kind of a big part of it. Is there anything in particular that you'd want to get across in terms of a message?
Yeah, I think it's taking the opportunity to review the overall user experience. In terms of when Jack mentioned when they want to integrate local questions with national questions, that kind of thing, is to take the opportunity to review that. We have our UX guide there, and I think that from in the beginning that wasn't very clear, and people just said, oh, we just have to have one separate form, but that's not the case. So I think that is a good opportunity moving to V6 to review that and create a better user experience. In terms of PSERF, is about really looking into the flexibility that it offers to create different workflows, so response workflows, because with PSERF now you have a choice in terms of how to respond to different clusters of incidents. How are we going to do this, and how are you going to do this year, and whatever local commitment you have made, and then make sure you create different workflows within your system that reflect the how you want to respond. So it's not just a single kind of standard process or workflow. There is flexibility in the system, and the system that you have, the tool that you have, needs to enable that. And the last point I would say that would be in terms of also to take the opportunity to review your local reporting and analysis of the data that you're collecting, because is a different taxonomy. Don't try to just to fit in whatever you did. So for example, I was saying start to look at the contributing factors in a different way now, and do analysis in a different way. It's not just there is an incident, look just at this incident, but to look at the data in a more holistic way, in not just one specific case or one specific question.
Yeah, it's interesting. I think there's still a lot of organisations who are, even though PSERF, probably get the time frame wrong, but let's say 12, 18 months plus, they're still going into every incident, reviewing every incident in the way that they've always done it, and actually they're not really using the framework in the way it was intended, I would argue. That's some of the things we're seeing anyway. And then kind of joining on, I guess, from the end question. So we talked about kind of version 7, version 8, version 9, version 10. How do you see the future of these patient safety frameworks? So, from your point of view, what's your kind of vision for LFPSE if we were going to roll it forward 5 years, for argument's sake?
This change, I hope, with everything that is within the change that we're proposing in the patient safety strategy, with PSERF, with other things that we are doing in LFPSE, is to reset the way that we looking at risk, and to I would like to see people developing new and kind of more innovative ways and proactive strategies for learning from patient safety incidents. It's the learning aspect. It's not the reporting is not the end. The learning is the goal, and we need to have strategies for learning, and then the tools will be there to enable that as you said, that we might not be just looking at what the reports they are volunteered by the staff, or there is another term that
I know what you mean.
Is and it's not just what is reported by someone, but what we can observe from other records, for example, clinical notes and all of this. And that works in two ways. One is to identify underreporting and trying to address why people are not reporting, and and then linking it with culture and training and other things that might be required there. So to get those insights from other data sources, to say, and also patient as well. So listen what the patients are saying. How does it match what's being reported, and then kind of so validate the data, the information that you're using. But also use the other source of data to, even ideally, depends of the degree of confidence that you're going to get in the future, to replace the report, as you say, because you can get this information through the day-to-day clinical notes and recording of activities and all of this, because you can do that. What was the variance between the work as prescribed and the work as done, and trying to find those points and find those issues and trying to analyze those. So that is that I believe that the technology will enable us to do. But it has to be, it's not just the technology, it has to be a proactive strategy for learning. The organization need to sit down and say, how I'm going to learn from this, and how I'm going to make better use what the information that's already available, and with the kind of a more learning focused analysis and reporting, because are we reporting to just to tick boxes and to what kind of assurance are we? Is we reporting for assurance, or we reporting for learning? And
we always talk about the outcomes. Sorry to interrupt. We always say it's not about collecting data, because, like you said, you're just collecting data for the sake of it. You're not actually answering anything. It is, if you're not learning from this and you're not changing and you're not driving better outcomes for patients, it's just meaningless ultimately. So I think we're definitely singing from the same hymn sheet. I think the one thing I'd like to see, and this is something that we're working on with some of the community elements we're doing as well, is that sharing becomes something that's much easier across different organisations, rather than it just being, you mentioned in silos. Whether we like it or not, there are still a lot of silos out there in terms of different organisations, in terms of different provider types as well. So it'd be good to break those down, and actually, with LFPSE as part of this, how do we just create more of an environment where there's a willingness to share, I guess, and then from that willingness to share, there's also a better opportunity for sharing those learnings as well. So again, just back to, actually, everybody's trying to do the same thing really here, aren't they? Everybody just wants to get a better outcome for patients. So collectively, we're going to do that much faster, I guess, and easier than we would do alone.
Yeah, it's sharing, and also is to generate more capacity in the system, so then we can learn from good as well.
Yeah.
It's moving away from that responsive mode and have a more proactive strategy for learning, where we can learn from good as well. So it's not just, wait someone to report something and then we jump into that specific case to respond. And then if there's any learning from that, how that's going to be used is instead of having a strategy that, no, this is my learning strategy, and it's going to be fed from source A, B, C, and D, and that's how we're going to come together, and that's how we're going to actually try some different interventions, and that's how it's going to be monitored and evaluated, and this is how it's going to be shared across the service. So that's what I hope we can get to that space.
I think it's probably worth us, again, I know we do this anyway, but kind of for the benefit of the listeners' podcast, I guess, just we share some of the things that we're working on as well. So, we're doing quite a bit around kind of learning dashboards and outcomes at the moment in terms of just, how we visualize things, how we talk about it, how we display these to our customers. I think it'd be useful as sharing that kind of the content with you guys as well. And then on your good, you got good care, we call excellence reporting. It's one of the first events we typically go live with for a customer, because actually it's fairly straightforward in terms of an event type, as we would call it. But the benefit is you're starting with something super positive as well, and you're starting with something that's kind of going, hey, look, what do we do really well? And let's kind of start to capture some of that stuff to begin with, because people are probably more likely and willing to report those sometimes than they might be some of the negative incidents. So that, from my side, I think is really interesting. And I know kind of obviously we talk quite often, Marcus, so I think there's definitely, we're both on the same journey kind of thing in terms of what we're doing with our product and what you're doing with your product. We're obviously having to work closely together now because we're feeding the information into your system. So I guess it's just make sure we keep that relationship and make sure we keep working together, especially not just the technology side of it, but this, the conversations we're having, the insights we're getting from the different people we're speaking to.
Well, if you want, I can congratulate you for being the first to LFPSE compliant, and again LFPSE V6 compliant. So
thank you very much. Yeah, it's a lot of work, as you probably know, went into it in the background in terms of setting that up and the testing. So thanks both for joining us this week, and thanks to everybody for listening. Join us next time for another new episode, and don't forget to rate and subscribe. And if you have any questions for me or any of the guests, please email whatthehealthtech@radarhealthcare.com.